Good morning, everyone. My name is Carrie Comer. I'm the Health Systems Operations Lead for the Health Systems Transformation and Innovation team here at the Washington State Department of Health. Thank you for joining us today for our third session in our 7-part webinar series in the health reform elements. Today's topic is going to be data and technology reform. So just before we dive in, I want to talk to you a little bit about what these open spaces are. And really, we wanted to have a platform or an opportunity to share information with people as new information was coming in about health reform initiatives and different activities going along around the system. And people were coming up with a lot of questions about the changes and opportunities and just different information they've been hearing. So we wanted to just create a space for public health staff and stakeholders to learn more about these initiatives and different forms of implementation across the system. We also wanted a safe place to ask questions. So this is the place to do that. That said, this session is being recorded. We have this pretty map here of the Healthier Washington Initiative. You might have also heard this referred to as SIM, or the State Innovation Model. And really, these open spaces were designed to talk about this and really get people ready for the different activities that they were hearing about with this the SIM work and the Healthier Washington work. This graphic is supposed to help you learn more about the strategies and goals of that. Really, the strategies on the right, or excuse me, on the left are the achieving healthier communities, integrating care and social support, and paying for value, and really doing that through state as first mover. The activities in the middle are really to help us get to the goals on the right, which are to improve population health, transform the delivery system, and then reduce per capita spending or lower costs. So we realized as we started talking a lot about SIM, or the Healthier Washington Initiative, that we also need to spend some time looking beyond SIM, or beyond that work, really about the health reform changes and transitions and opportunities in the system altogether. And so we're doing that through this 7 webinar session, where we'll be covering topics like insurance and coverage reform. Today we're talking about technology and data reform. Our next section will be on data reform. And so I think today we really want to have Caitlin Sefford really diving into some of the elements and concepts of data and technology reform to give you an idea of what that might look like moving forward and where some opportunities might exist for you and some of our partners. So really, this work is all based on this framework of the triple aim, which is the backbone of the Affordable Care Act, or the ACA. And that's the model that will drive the innovation and improvement throughout the whole system over the next, we've been saying decade, but I'm sure it will go beyond that as well. And really, just a reminder, the triple aim is better health, better care, and lowering costs. So we believe that improving the health of whole communities and improving the quality of care and experience that people receive care, and lowering the cost will actually have a more sustainable system moving forward.
Okay, so now we're actually going to move into the element of data and technology reform. And just so everyone knows, these are intended, all of these webinars are intended to be a very high-level overview of each element, really kind of spark your interest, so that we can talk a little bit more in depth about it with you on a one-on-one basis, or if you want more topics within a particular element covered, doing that on a smaller level rather than this wide group level. So just keep that in mind when we're going through this. It's just meant to be a teaser, and if you have any questions that are more detailed, those are more than welcome. But the information we're presenting is just very high level. So starting with technology and data reform, we want to just start out with data reform, and really, what is data reform? What does that mean? And how we're going to define it today is really going over some of the key terms you may have been hearing lately. I think data reform is not siloed to just health and healthcare and how that's shifting. It's really happening across our whole system, because the way that data can now be collected is is way bigger than it ever has been before. So big data is one of the terms that has been most referred to when talking about data reform. And there are three sort of key concepts to big data, three terms involved with big data, and that is volume, velocity, and variety. So we have more data available to us. Like, I think I read a stat that was like every 2 hours than we had available 20 years ago in one day or something like that, something ridiculous. So we have a massive quantity of data that can be collected all at once. And it's moving across systems and faster than it ever has before. So that's where that velocity comes in, and really being able to harness that velocity and use it to your advantage. And then the variety of data sources that we have. We now have social media platforms, and even being able to track the way people spend money and the way they search for things online, and how that really helps us understand human behavior. That's an incredible platform for big data. Another term that you might hear a lot is analytics, and this technically refers to qualitative and quantitative techniques and processes used to enhance productivity and business gain. So these are just a lot of different platforms. Sometimes they're tech platforms, being able to synthesize a lot of that data and analyze it to make it more usable for the user or the business to actually increase their productivity. For instance, being able to analyze how many sales they've done, how many products they've moved. Sometimes that's in a visual way, so that it's just more understandable for them to make better decisions, decisions that maybe lessen the waste that happens in companies. Same with healthcare. A lot of these are driven to help lessen waste in healthcare and health. Measurement, I'm sure that's not an unfamiliar term for public health. I think we all have been dealing with measures since the inception of public health, but that's something that's a little newer for other people, and it's measurement and the different ways of being able to measure things is being more widespread across our entire society, and making sure that the way that we measure things actually helps increase our productivity. And again, really trying to reduce the waste that any sort of system creates. The last one that we just wanted to throw out there is data visualization tools. And this is really geared to make data more understandable to a normal everyday user, so that it's not just something that is for people who live in the data world all the time. We want to make sure it's able to be understandable for just the layman to access online and look at, say, for instance, their immunization rates. And I'm going to show this. We're going to show this example. This is something we haven't done yet in a webinar, so hopefully it's working. Many of you may have seen this lately. I think this came out in the news last week. This is King County's immunization rates. This particular map shows the measles, mumps, and rubella and immunization rates for kindergartens in King County. So this is an example of one of those visualization tools, being able to really understand and map out and increase the size of your dot depending on how good your immunizations are. You could also increase the size of your dot to show how bad your immunizations are. It just kind of depends on the lens you want to take. But that gives people a good understanding and idea of where they really stand. I wanted to call out my hometown over here, Vashon Island. We have one of the worst immunization rates. When I first started here, I said I was from Vashon, and they were like, oh, I got this really like, oof, sort of kind of look in the midst of whooping cough epidemic. So we just wanted to show this as an example. All right. So then why is data reform important? Or why are we kind of talking about it more broadly? Part of it is that all of our decisions that we're starting to make are really data-driven, and we need to be able to have the right tools at our disposal to make sure that data is actually accurate data, it's clean data, and it's data that people are interpreting correctly. So at the policy level, all of our legislators and our from the state level, the local level, all the way up to the national level are really using data to back up their policies, and actually that's driving a lot of the policy shifts that we make, either in Congress or in those types of law creation platforms or in rule creation platforms. So it's on all levels of government. And it's the same thing is happening at business, hospital, and clinic levels. A lot of hospitals and clinics use data to help understand how their patient flow is going to work, how to improve that to make sure patients are getting care better coordinated across different levels of a hospital, for instance, moving between the ER to the ICU or to surgery, and how all of those are transitioning so that that sort of patient flow isn't disturbed or disruptive to the whole care unit. Additionally, a lot of the data is driving this sense of having things be evidence-based. A lot of that is being pushed out there now. We want to make sure we have a strong evidence base for everyone to be able to use. So that's happening at the policy, and a lot of it is at the national level. They're at least incentivizing people to use evidence-based platforms and evidence-based criteria to deliver care, or how we do our programs even in public health. A lot of it has to be based on evidence-based practices that have been used before. And that's happening at the care level as well. We use evidence-based guidelines to deliver care, and the hope is that those guidelines will help create the best system of care, and they won't have to do duplicative services, or they won't have to sort of do redundant services, because several people are, kind of means the same thing, I guess. But the point of it is that you're getting the right care at the right time immediately. We just want to throw up a yield here. So I kind of inferred before, we don't want people to misinterpret the type of data that they're getting. And so how can we make sure that data is actually well done enough and people understand how to use it well enough to actually make the decisions they need to make based on data, or even reference the right data in a good way. One of the articles I was reading in preparation for this presentation was saying how President Obama referenced a particular data point in his State of the Union address that was actually incorrect, but he was using it as a policy platform to push a large policy agenda. And so making sure that that doesn't happen, that's what we really have to watch out for now. And the other thing that I think providers are getting concerned about is having evidence-based care practices really almost put a damper on the way that they can provide care to their patient for what's right for their patient, and kind of taking the decisions out of the hands of the providers, and I think that worries them a little bit. And that was never the intent of evidence-based guidelines. It was just supposed to be guidelines, but the way that they're being pushed down, I think, have people concerned. So just a yield to put up there as we have these discussions to make sure those concerns are addressed. And now we're going to move on to technology reform. And this really kind of falls into a couple different buckets of key terms. You have health information technology and health information exchanges. So health information technology is really the technology part of it. So all the electronic devices and online services that make it possible for healthcare providers and public health professionals to better manage and share patient care and do population health. That's what the intent of health information technology is. And it's getting broader and broader as the years go on. It kind of was just referenced more as like electronic medical records or electronic health records, and now it's even branching out to how you use your mobile device to be able to track your own health, and how that is more patient-driven or personal health-driven rather than provider-driven. So in this vein, I just want to make sure people understand the difference between an electronic medical record and electronic health record. We started out, when we were first starting to talk about health information technology, it really started as electronic medical records, and now we're moving into a more broad term of electronic health records. So EMRs are intended to sort of stay with the clinic. They're for a particular provider and the way that that clinic uses a medical record for the patients involved with that clinic. But that information doesn't necessarily transfer well to another clinic. So an electronic health record is supposed to be a platform that can kind of stay more with the patient. So it's more about the patient's health, that it can transfer between clinics. And that is supposed to create better care coordination and ensure that health outcomes are actually being achieved across multiple settings of care. Health information exchanges are a system in order to help make this possible, and this transfer of data possible. The official definition, it allows doctors, nurses, pharmacists, other healthcare providers, and patients to securely access and share a patient's vital medical information electronically. And the end result is to improve speed, quality, safety, and cost of patient care. And so although health informations are intended to share this patient data, it also helps generate a lot of public health data that we can also use, and aggregates a lot of the patient data and what we usually do is be able to weed out all of the patient information, all the identifiable information, so that it is actual aggregate data that the public can then use, that we can use as public health professionals to direct our work. We want to go through a couple of examples of what health information technology really looks like. So you have online scheduling. You can actually schedule appointments with doctors now online through their websites, which is a really fantastic platform. I know for myself, I grew up in a technology age, and I actually don't like to talk on the phone that much, and it intimidates me to call doctors' offices, so I prefer online scheduling. I am so excited that more doctors are taking this up, and it just makes it easier for you to kind of fit this into your day. It's sometimes hard to make a clinic appointment, especially if it's about a particular confidential service. It's hard to do that in a setting like maybe we work in CubeLand here. So another example is a virtual visit capability, and this is often called telemedicine or telehealth, and telehealth is a little bit broader than just telemedicine, but this gives an opportunity for a patient and a provider to actually do a health visit over a mobile device. And so that might be a tablet, it might be a phone, and it could be done if the patient is in a clinic and the provider needs to talk with a specialist, they can bring that in, but it also could be done with a person at home or in a pharmacy or something like that, and they can connect to their primary care provider to receive test results, to get some counseling on different medications that they might need to use, things like that. That's what our virtual visit capabilities are really for. Wireless access is one of the biggest parts of health information technology. That's kind of what's facilitating all of the work, all of the data that can be transferred and all of the ways that we can actually connect to each other. And this is becoming even more widespread too, and finally DOH even got wireless access for everyone to be able to use. And in other countries, they have free wireless access everywhere, and they have them across in public streets and not just limited to cafes or individual businesses. And so hopefully one day we will also have that similar infrastructure. There's also some very innovative stuff going on with geographic information systems, which is something I think is pretty familiar to a lot of public health people. We have something like this in environmental public health, the Washington Tracking Network, which is really a way for us to look at all of the environmental health concerns that are happening across the state and map them so that we can better direct our resources. And that type of technology, I think, is being spread to more programs for programs to be able to use in different ways. The other thing that was a really handy thing that was the radio frequency ID tracking, and this an RFID chip can be put into a bunch of different things. A great example I think that we'll probably get to one day is being able to put one of these chips in medical or insurance cards so people could then carry that with them, so say all of their health records are on that card and they can transfer that between providers, and so that doesn't necessarily have to ensure that the technology is working across different electronic health record systems. Canada has something like this. They have a National Health Service, and they actually, every person is a card-carrying member of their National Health Service, and they carry their patient information on their card. To do something like that here, I think would be quite different because we all have different insurance companies, but it would be pretty fascinating to try to figure out how that could work. There's another way you can use this is to put tracking tags on your medical supplies so that you can be really aware of when your medical supplies are coming in. Say there's a massive accident or something at a hospital will be able to track when they can get more supplies, say from a different hospital or from their supplier that's in the area, which will be really handy in situations like that. And then some HIE examples. So like I said, electronic health records are one of them, and being able to transfer those. The HIE really facilitates that transferring between providers and clinics. So, and most of your information now is going to be shared or stored or contained in a primary care provider's office. So when you have to go see a specialist for a particular procedure, then that can transfer across the health information exchange to get to that provider, which then can get back to the primary care provider with whatever results happened. Another one is a data repository, and this is the aggregation of data and how we're going to be able to collect all of the data in one and pull it out for our use to direct our resources, to create some of those evidence-based guidelines, to make those data-driven policy decisions. That's what these data repositories existing within an HIE will really help do. And you have care planning systems, which are the way you can use mobile devices, which are happening more and more, all of the health apps that you can download and be able to track when you take your medication, and I know Sue Grinnell found this great one about an inhaler tracker, and I have asthma, and so you can track how many uses you've done for your inhaler, which is really great when you have little kids with asthma, and being a parent, being able to track how many times they've done their inhaler or their nebulizer or anything like that. Those types of apps are becoming more popular and really important. And the data shared from those apps, I think, would be really important to understand and know. You have e-referrals, too, and this can happen over a virtual visit, say, that we just talked about, but it could also happen while you're in the patient office or the provider's office, and you're doing a visit, and you actually can get an e-referral from that provider to a specialist immediately. And additionally, you can also get feedback. So a lot of what health reform is about is improving patient care. And this allows you to provide immediate feedback online, which you don't, because right now a lot of the ways you can do that is through a paper form that you then have to mail in. But they're shifting to being able to do that online through your patient portals and giving them that feedback immediately so that the provider can then immediately use the feedback to change the way that they do their, provide their care to their patients. So why is this important? Why are we talking about health information exchanges and health information technology? The technology really facilitates this idea of real-time data collection, being able to capture the data that's happening at every moment of the day all at once and be able to use it to our advantage immediately. Again, like I've been saying, it provides better patient-provider connections. It really facilitates those connections and does better coordinated care and access to care. A lot of these platforms are giving people broader access and easier mechanisms to access care, make appointments, and things like that. And our hope is, through this care coordination, that we really can reduce the duplication of efforts, which is one of the biggest cost drivers that we have in our country right now. There are some policy supports for all of this stuff. The HITECH Act is one of the ones you might have heard of the most. This came out of the Economic Recovery Act of 2009, a subset of it. And this is actually what jump-started a lot of the infrastructure for building health information technology in our country, helping providers get on electronic medical records or electronic health records that were actually certified by the federal government to achieve the different standards that the federal government wanted them to achieve in order for all patients to be, or all providers to be able to actually have a platform that can talk to each other and can do that coordination of care. The other one is this FDASIA, which I just can't help but call FDASIA, and I don't know if that's actually the way you call it, but is actually done through the Food and Drug Administration, and it's in consultation with the ONC, which is, I just forgot, is the Office of the National Coordinator for Health Information Technology, I think, but for short, they just call it the ONC, and that directs a lot of the health IT stuff that our federal government does. And so they're working together to actually propose a strategy and recommendations on doing a regulatory framework for how we do health information technology, including medical mobile applications and other innovative efforts that are actually secure, and they're securing patient data. And that's a big important part of that. HIPAA, again, feeds into all of this, and I know that we're all pretty familiar with HIPAA and the privacy and security standards that HIPAA lays out, but HIPAA was, when it was done, already set a base for how to do that for electronic information, so it was actually pretty forward-thinking when it was passed in the 90s, and now it's being updated even more with rulemaking to ensure that all of that electronic information is secured and how providers can secure that and how hospitals can build infrastructures to secure it, or clinic systems. And then you have this new added element of the health insurance exchanges, which provides us with a wealth of data about the way that people are purchasing health insurance, who's purchasing them, how often they're actually maintaining their health insurance, the different types of health insurance that they need, and perhaps why. Even the user experience and the interface is all really important to help us understand how people are using this health-related websites and things like that. So that just gives us even more data to tap into. We would be remiss if we did not mention the importance of privacy and security. So I mentioned HIPAA, and again, that is, I think, probably one of the biggest things that people want to make sure happens, is that they maintain HIPAA, and there's a lot of legal impacts for them not maintaining HIPAA, so there's a lot of focus on that. And then you have meaningful use guidance, which we're going to go over. But part of what meaningful use does is they actually set up standards that providers have to meet in terms of privacy and security of your electronic health records and how those are transferred between providers. That's an important measure that they have to meet. And there's also a new focus on how to prevent cyber attacks or how to deal with cyber attacks on hospital information systems. I am in graduate school, and one of the speakers we had at my last class session was the Chief Information Security Officer for Children's Hospital, and he was talking about all he does all day is to make sure that his system doesn't get hacked into or slows down or gets taken offline because somebody wants to interfere with their system. It's pretty fascinating, and some of the hospitals have actually had to deal with some attacks that were meant to slow down their system. Boston Children's Hospital was targeted by a particular group, a hacker group, and they actually shut them down, shut them completely offline for 6 days, and all because of one patient that they were trying to help facilitate some news around and help that patient get some help. And so it's pretty interesting. They have to protect against that at all times. We need to also talk about interoperability. And it's a long word, and but what it really boils down to is making sure that all of these systems can talk to each other and actually transfer the data in a clean way, that all of the data is transferring and not just pieces of it. One of the biggest challenges we currently face is that even if a provider group, even within one hospital system, they may have the same electronic health record platform, but even within that hospital system, they won't talk to each other. And so this is really trying to figure out how to make them talk to each other and make sure that they can transfer that information, and it's not a wasteful effort. The ONC has been developing an interoperability roadmap. It actually just got released a couple of weeks ago. This is one of the graphics from that roadmap, and I think it at least sums up what they're trying to do and trying to influence within the system as it gets pushed forward. Okay, so let's go into what meaningful use is. So meaningful use, again, spawned from this high-tech act, and it's based around Medicare and Medicaid and making sure that the providers who participate the most in those two payment systems can actually have electronic health records that are able to capture all the patient information needed while also being able to code correctly to the Medicare and Medicaid system to reduce the redundant services, to reduce the waste that happens in clinic settings. So in order to do this, they have set up 3 different stages so far for how people can transition onto electronic health records. So they're Stage 1, Stage 2, and Stage 3, and what providers need to do is attest that they've actually met all of the standards. So there's some core standards and there's some additional standards. They need to at least meet the core standards and then also have some additional standards that they can add on. It is a requirement of this that you actually get an EHR or else you will be penalized, and they're still, I think, developing guidance on when exactly everyone has to have an EHR, because some systems are really small, like the federally qualified health centers that are really tiny, or even individual clinics that are really tiny. It's much harder for them to be able to afford electronic health record systems. So how do you help them through that? But this was an incentive program. They actually had money attached to people getting on an EHR and actually trying to meet these standards. So what does meaningful use really mean in terms of what they have to meet? This chart actually gives a couple of examples of some of the things that they have to do through Stage 1, Stage 2, and Stage 3. So Stage 1, I think you had to attest by last year to be qualified for Stage 1 and move into Stage 2. And Stage 3 guidance actually just got released. So some hospital systems who have had electronic health records for many years are ready for Stage 3. Other smaller systems aren't. And actually not a whole lot of people were able to attest to Stage 2. And so they're kind of trying to look at the usefulness of meaningful use, I guess you could say. And there are a lot of people questioning whether or not it was the right way to go. So it still remains to be seen how productive this will have been. We want to give you an example of what this really could look like working all together. So I know this is a lot to look at, but in one corner up in the, trying to think about, so upper left-hand corner, you have the health media portal, and you have things that are related to almost your personal health, your mobile devices, your social media profiles, and all the health alerts that you can get personally. On the upper right, you have the patient portal, what you use with your provider system to talk with your provider, manage your care, and manage your care with your providers, all contained in your patient portal, which hopefully I think one day could connect to your insurance portals, which I think is the ideal system that we could see. Then in the bottom right, you have your physician portal, who's also going to have a portal to be able to connect with you and monitor your care from a distance. You also have the community portal, which is where public health lives, how we use the data that is kind of aggregated in the center, which is the cloud, and the networks that flow between all of these different sections of health information technology and exchanges. So, say you are wanting to track your Fitbit or your Nike Plus Fuel Band or your Google Fit and be able to monitor the activity that you're doing in a way. And then you want to make sure, because your doctor said that you needed to get more exercise, you want to make sure that your doctor can actually know that you're doing it. So you have this contained on your mobile device, and then you can update it through your patient portal. And your patient portal would hopefully also have an app that you could just input it all in. Maybe it's even connected to your Fitbit. Some of them are doing that with certain large systems. And then your doctor will be able to see, oh yeah, they've been actually running 4 times a week, and that will help them understand how your health is improving. And monitoring, say, your blood pressure, and if it's still not decreasing, then maybe activity wasn't the answer. What else can we try to help get their blood pressure down? And all of that information is connected to our community portals, which then public health can really use in an aggregated format to understand how much more active people are, how much more people are eating healthy, how people are actually using the activities around their community. A lot of the health apps that you can use actually map if you're running, if you're walking, and where that map is, and how is that data used to perhaps do some urban planning or see how we can build in more sidewalks for people to actually use safely, to exercise safely. And we can also use that to create sort of a herd mentality to get people actually continue to do exercise. So then it goes back full circle to create health literacy campaigns that then get people using their mobile apps, and you start the process all over again. That's kind of an example of what an ideal system would look like in the future, hopefully not too far off future. I don't think we're too far from getting this to work, but you do really need a lot of infrastructure built in around that. We're going to do another example and kind of walk through what it looks like in a clinic setting. So we're going to do this quickly. So in our last webinar, Delivery System Reform, we introduced you to Rosa, who is our real-world example to show you what it looked like to go through the future system. This time we're going to introduce you to Dave so that you can understand the difference between the future system and the now system. So Rosa is representing our future system, and David is representing our past, or our current system, which is a little bit in the past. So you start with your pre-clinic visit, and Rosa gets to schedule her appointment online and sees through her patient portal that her provider is offering hours Monday through Sunday from 7 a.m. to 7 p.m. so that she's not relegated to business hours when it's hard for her to get off work to go to an appointment. Whereas David has to call, and he can only get appointments 8 to 5, which is really hard for him to actually meet. The intake form that Rosa needs to do with her provider is actually available online that she can just update before her appointment. Whereas David has to come to his appointment ahead of time, at least 15 minutes, to be able to fill out all of the forms he needs to fill out. On the day of the appointment, Rosa can actually just check in online so that her provider knows that she's there. She uses her mobile app to tell her that she's there. Perhaps there's just a computer up front that she can just click and say that she's there, and that'll give sort of ping the provider. Whereas David has to wait, has to tell the receptionist that he's arrived, and then perhaps wait for several minutes before he can actually get in to see his doctor. So Rosa and David would be met by a medical assistant, and a medical assistant for Rosa would take her vital statistics, update her electronic health record in the room with her, really talking through the different things that are happening. and asking about her current lifestyle, things that are going on in her life, doing a very broad assessment of her health. David has to wait for his medical assistant to arrive. Maybe they're entering stuff into his health record. Maybe they're just taking his vital statistics and still charting it down for the doctor to see later. And then Rosa is also escorted, or perhaps in the same room with her clinician, to really talk about her health concerns. And her clinician is going to be, it could be a nurse, it could be a physician's assistant, or it could be a medical doctor. It could be a range of clinicians. Whereas David probably is going to see a doctor, and he may have to wait a little bit longer because sometimes doctors have to spend more time with their other patients if they need to address particular health concerns. After the clinic, Rosa's clinician is able to contact additional health specialists in the room with Rosa for any follow-up that Rosa needs, whereas David is going to probably have to make those appointments on his own. He may be told what specialist he could go see, but he also may have to just go look on his insurance website, figure out which one is going to be covered. Rosa's really going to have, her provider is going to have those connections already built in. She'll receive an e-confirmation on her phone, and a reminder will be set for her to go to that particular appointment, and David will have to do that all on his own. And if Rosa wants to really understand everything that's happened with her health, she wants to recall something as to why she's going to the specialist or what she needs to talk to the specialist about, she can actually look at that all on her patient portal, on her patient records that's housed online, accessible only to her. Whereas David will have to call his provider, get his patient records actually sent to him so he can read them manually, which, as you can see, makes him a little frustrated and tired. Okay, so we're going to go quickly through implementation in Washington. A lot of this stuff you guys have heard about before, and I think a lot of it also is things that we need to figure out how to do as public health and what our role is. So these are a lot of different data sources, and this is just a sampling. We have way more than this in our state, but DOH does a ton of data work. The Department of Health, local health does a ton of data work, and these are just some samples. Programmatic data that exists, vital statistics that we have in the Center for Health Statistics here at DOH, behavioral data that we have with BRFIS and the Healthy Youth Survey, and then the Washington Tracking Network, which you mentioned earlier. The Healthcare Authority has a bunch of data related to Medicaid eligibility and demographics, which is extremely useful, especially to our work. DSHS is the same. They also have a lot of data on vulnerable populations. Now we have a lot of data housed in our health benefit exchange. It has been a challenge to get that data. Creating a data sharing agreement with them. They're still a new agency, or they're not even a full agency. They're a public-private partnership. That's something that we're having to work through. But eventually, when that data sharing agreement gets worked out, they will be able to give us a wealth of data to compare with what we have and really see the utilization of health insurance in our state. OFM also has a lot of population income-based data, things like that, general data for the population of our state. Like I said, this is just a sampling. That doesn't even include everything that's here. We also have a health information exchange that's being created here in Washington. Healthcare Authority is the current lead, and they've contracted with One Health Port to help create this health information exchange, and we did receive $11.3 million to help start the infrastructure for this. And I think Carrie was telling me there's 95 different sources that go through the health information exchange right now.
Providers signed up.
So 95 providers signed up to push information through the health information exchange to get it across the different sources. Lastly, we also have all of this happening, a lot of different programs, and we will send these slides out so you can actually see some of the different things that are going on. One of the things that I did want to call out is the all-payer claims database. This is something that has been generated out of the innovation work, and what the intention for this database is to really aggregate all of the claims that happen in our state, so we can look at what the actual cost of care really is and how much it costs per different insurance companies or different providers, what they're charging. This is really supposed to provide transparency to the public and to everyone else, all the partners in a health system, to really understand how healthcare is utilized and help us lower the cost of that care. That's what the all-payer claims database is intended to do. Last year, it was included in House Bill 2572, which was really the infrastructure for our innovation work. But it was distilled down a little bit and actually only required state-funded insurance or health care claims to be included. And so all of the private insurance did not have to be included. That is hopefully changing. This year they introduced new bills that are actually governor request legislation to have everyone putting in information to the all-payer claims database. And that is moving along through both houses. So I think that it will probably hopefully pass this year. And that'll get started soon. OFM is the lead agency for that. The Washington Health Alliance, which used to be called the Puget Sound Health Alliance, they already have an informal all-payer claims database that's really Puget Sound centric. And so they've been working very closely with OFM to help inform what the infrastructure could look like for a statewide all-payer claims database. The other thing that we want to call out is the analytics, interoperability, and measurement on the right-hand side of this table. That's the investment in the Healthier Washington initiative. It's actually the largest investment. It has the most money dedicated to it. And it's really intended to create more interoperability between all the different data sources, a data platform. Also be able to provide analytics and data visualization for people to utilize that data in a more friendly way. And there's a lot of measurement work that goes in with the Healthier Washington initiative. We had the Performance Measures Coordinating Committee actually finalize a list of our starter measures at the end of January. And so those starter measures are things that will help drive our shift to value-based purchasing and how providers actually provide care to their patients. Okay, so for these webinars, our intention right now, as we said at the beginning, we're recording all of them. So hopefully they will be posted. I think we're going to post them on the external website. We were trying to do some different platform, but I think we're going to get them posted externally on the website so it's easy for everyone to access for all your partners, all LHJs, and everything. So the Healthier Washington initiative is getting going. So the other thing that's been happening, just so everyone is aware, we announced this at our last webinar, but we want to make sure that everyone knows that this is happening. There were some funding decisions made about our positions. So Sue Grinnell is going to continue in her position. She is also going to be what is called the connector between the Healthcare Authority and the Department of Health for all of the Healthier Washington work. She will have one support staff person or one staff person underneath her. So 2 of our positions are ending. And what's happening with that one position, that we're still trying to figure out what that one position could do, because our team is really structured around sort of playing off each other's strengths and helping fill in for each other's weaknesses in either information or skill sets. And so I think what the work of that one person will do will probably shift, and what that means for how we go with public health in this work will also shift. So our positions end at the end of May, May 31st. And in between now and then, what we really wanted to focus on, I think, a lot is to help public health staff, so either DOH staff or local health staff or any partners, to really get a good understanding of what these elements are. And so I know that our webinar series is a really broad overview, but if anyone wants personalized training or technical assistance, we really would like to be able to provide that before we leave. So please let us know, and we're willing to come to you, local health, wherever you're at. We thought for a long time about doing some sort of road trip. So give us a reason to do a road trip in the last 3 months. And so I think that's everything we needed to say. I think we're right on time. Yeah. So thank you, everyone, for attending this one. And let us know if you have any other questions.